200 disorders included under the category of rheumatological problems. And, all problems have very diverse manifestations. Manifestations are just not confined to the joint. And majority of these diseases are multi-system diseases. That is, with joint, it involves vital organs like lung, heart, kidneys, brain, so etc. So therefore, commonly what one needs to understand that if someone is having pain in the joints or pain and swelling in and around the joint, which is persistent, there is early morning stiffness of more than 30 minutes duration, or along with that one is feeling very fatigued or having fever, or there could be dryness of eyes and mouth, there could be rashes over the body, there could be excessive hair fall along with joint symptoms, or there could be oral ulcerations, genital ulcerations, there could be pain in the back which is more in the morning or during the night when one is in the state of inactivity, and that gets better with activity. There's something called an degenerative joint disease, which is the commonest of all conditions, rheumatological disorders like osteoarthritis, which is non-inflammatory condition, which usually happens in the older age group, in the elderly population more than 60. But these days we see these problems even in the early age group because of lots of lifestyle modification. So as I said, like if someone is having pain in the joint, stiffness lasting for more than 30 minutes, then one can consider himself having some kind of musculoskeletal problem. But as I said, other symptoms also, like having prolonged fever, not responding to any drug. Sometimes these patients are mistaken for having tuberculosis. They keep on taking anti-tubercular drugs, and later on, when they reach to a right doctor, and then the diagnosis is made that they have some rheumatological illness, any autoimmune illness, particularly systemic lupus erythematosus. There could be simple muscle pain. So we need to understand that these rheumatological disorders can have very, very diverse manifestations.
Sorry, I was on mute. Sorry. So I'll go again. Thank you so much, Dr. Uma, for your broad explanation of various symptoms which can be the manifestation of this disease. I would like to go to Dr. B.G. Dharmanand on it, and we'll try to understand that, doctor, who are the patients who may be having, or the people who may have a higher risk of developing rheumatological disorders.
As you have already know by now, by the explanation of the previous speakers, rheumatological diseases are not one homogeneous group of diseases. And various age groups are prone for various types of arthritis. And rheumatoid arthritis, which is the most common and most popular of the arthritis, occurs predominantly in women of middle age group. And the disease called lupus or systemic lupus erythematosus occurs in younger girls between 15 to say 40. There are diseases like osteoarthritis, which occurs in older women from 50 onwards, they get it. And there are few diseases called giant cell arteritis, polymyalgia rheumatica, etc. It can occur in elderly population. So rheumatologic diseases are not homogeneous group of diseases. Even children get many forms of arthritis. That is called juvenile idiopathic arthritis or juvenile rheumatoid arthritis. Even kids can get it.
Okay, sir. Thank you so much for this. So when we come to understand that this is, not a single manifestation of this disease, it's a contribution of multiple of that. Let me also go to Dr. Sasank on this to understand that what are the preventive side of it. Let's say if there can be multiple risk factors to it, and multiple age group can be probable, patient group for this or may develop this. So what are the preventive mechanism for avoiding such kind of diseases?
Okay. When we come to this, let me break the entire rheumatological ailments into two. One, as Dr. Umakumar just said, is degenerative. What does one mean by degenerative type of arthritis? It is basically wear and tear type of arthritis. So this is something that one would expect in the elderly age group. You must have seen senior citizens complaining of knee pain when they squat, when they sit on the floor, when they climb the stairs. So in degenerative conditions, what happens is in knee osteoarthritis, which is the most common type of degenerative arthritis that we see, the knee has two bones, and on top of those bones, in between those bones, there is a cartilage which keeps the two bones apart. With age, there is wear and tear of the cartilage, because of which, whenever there is movement, the bones come closer to each other, rub against each other, and that is what causes the pain. So this is degenerative. Even lumbar spondylosis that you must have heard about is to some extent a degenerative type of rheumatological ailment. In this, the main risk factors are all mechanical risk factors. Anything that puts undue pressure on the back, undue pressure on the knees, is something that is going to worsen this type of arthritis. So the habit of squatting, habit of sitting on the floor, habit of sitting on the floor with the legs crossed, this is something is a major risk factor for degenerative knee osteoarthritis. As far as the back is concerned, strenuous physical activities, bending, lifting heavy weights is something that becomes a risk factor for degenerative conditions of the back. The other type of rheumatological ailments, apart from this degenerative, something that rheumatologists more commonly see is called as inflammatory arthritis. What exactly is inflammatory arthritis? Inflammatory arthritis, we call this as an autoimmune ailment. What does one mean by autoimmune? Our own immunity somehow mistakenly starts thinking that the joints are foreign and starts attacking these joints. So what happens because of this immunological attack is the joints swell up from inside, and this is what causes the pain and swelling. Now, as far as this arthritis is concerned, there are not many risk factors. Genetics is one of the important risk factors. Most of the arthritis are known to run in families. So there are genes, something like HLA-B27 that is seen in ankylosing spondylitis. So these genes are one of the important risk factors. Sex, ladies tend to have most of the arthritis more common as compared to males. This is because of the female sex hormones. So these are the two things that probably one cannot change. You can't change your genes, you cannot change your sex. The reversible or modifiable risk factors, one of the common thing is smoking. Smoking is known to induce multiple autoimmune illnesses like rheumatoid arthritis. It is known to worsen ankylosing spondylitis. It is known to reduce the response to therapy in ankylosing spondylitis. So modifiable risk factors, if you look at, this would be an important risk factor.
Thank you so much,
So
Doctor.
this is as far as the risk factors for various rheumatological conditions is concerned.
Thank you so much, Doctor. So let me go to Dr. Aman Sharma now. And Dr. Sharma, during this lockdown, when the people or patient cannot actually access healthcare as usual, what is your take on that? That how many patients may be having an additional or special requirement for extra care or some kind of precaution, who may be suffering already from any of the rheumatological disorder, and what precaution they should take care these days?
Yeah, I think this is a very important question. The first thing which comes to one's mind in the patients who are having rheumatic diseases, we have to remember that many of them are on, as Shashank very beautifully pointed out, that the cause is the body identifies some of its parts as foreign and starts attacking it, and there is a heightened immune response, which is reined in by the drugs which we give to these patients. And our patients are generally aware that they are on drugs which we call as immunosuppressive drugs. Sometimes some of these diseases require exposition or intake of corticosteroids also. And the first thing which comes to any rheumatic disease patient's mind, the question which comes is, should I continue the drugs in the era of COVID, which bring the immunity down. So the most important thing is that no drug, if the patient is having a stable disease is under control, patient is doing well, the most important thing is, and why it is important is that in our country and in our culture, most of the opinions come easy and everybody gives opinion to the patients. And that is what sometimes is the undoing of the patients. So the first thing that is told to the patients is that you should stop so-called immunosuppressive drugs. The most important things that the patient should remember in this scenario is that the therapy which they are on, with which the disease is controlled and stable, should not be changed without the doctor telling them to do so. Especially if they are on corticosteroids. Generally, they are on very low doses of corticosteroids. Especially for arthritis, we never give more than 7.5 milligrams, which is a physiological dose. So abruptly stopping the therapy can do more harm than the good. That is number one. Number two is, many times the questions are that whether we should stagger the therapy. There are other therapies like stronger immunosuppressive drugs like biological agents, and even if they, as was told, that rheumatic diseases is a big spectrum. On one hand, you have degenerative diseases wherein you have some therapeutic intervention. On the other hand, you have a common disease like rheumatoid arthritis, where we give the oral tablets which are known as methotrexate and sulfasalazine and hydroxychloroquine and leflunomide. Then there are biological drugs which these patients are on, and there are other diseases which are life-threatening, in which there are other enhanced immunosuppression which also is given. So the rule of thumb is, if there is a stable disease and you do not have any evidence of the infection, you should not be contemplating interrupting or stopping the therapy. Number two is, these patients should remember that there are advisories issued, there are advisories available on the various rheumatological disease bodies websites. Indian Rheumatology Association also has an advisory for the patients. The other question is the other preventive measures like social distancing, self-isolation, and whether they can, or there are enhanced preventive measures which these patients need to take. So there are small subset of patients who are on certain forms of, who are so-called high-risk patients, where they are on multiple drugs. They should that's a very small subset. They should be self-isolating themselves, but the large proportion of patients, they just have to take the common social distancing precautions, which would be there for the general public. And we should always remember that, we've been told about smoking, so smoking should be stopped. I'm sure we'll talk about the diets, the exercise, and other things. But the one key message is from my side is that treatment should not be interrupted, because that's something which is very dangerous. If the disease goes haywire, then we might have to use higher immunosuppression, which might be dangerous. And then we have to be alarmed about the early signs of this infection and all that stuff.
Thank you so much, doctor. So important key message is coming that the treatment which people are undergoing or patients are undergoing should not be stopped voluntarily. You have to consult your doctor. Let me go back to Dr. Danda on that. And Dr. Danda, there is a possibility of, this lockdown has also disrupted sometime, some kind of supplies related to medicine, and the excess, and maybe some high risk patient would be trying to stay away for the purpose of extra caution of isolation or social distancing. So what risk you could figure out of it if the patients are not getting enough supply of medicines, or in certain cases may feel that the immunosuppression part of medicines can also lead to more risk of catching infections like COVID-19?
Thank you for this good question. As far as the recommendations go, both from American College of Rheumatology and other credible bodies, they do not recommend, as Dr. Aman said, till someone is at risk of exposure or suspected or symptomatic of COVID, we don't have to stop the regular ongoing treatment. However, as Aman said, some of the drugs are classified as immunosuppressive. We don't stop them immediately unless the patient is exposed to or is having symptom, because the primary disease, if it is not treated with immunosuppression, that itself can make the person high risk. So treating the primary disease with the ongoing treatment is very important. About the drug supply, short supply, yes, certainly there was short supply. It is one of the drawbacks, but I must say that lockdown had many benefits. It has, overall, this is the only thing which has made a difference in containing to large extent the outbreak, in spite of some difficulties, in spite of here and there some violations of lockdown, because as of now there is no treatment. The patients with rheumatic diseases are equally susceptible to get the disease, and especially some of our patients, like those who have complications like interstitial lung disease. It happens in rheumatoid arthritis, it happens in systemic sclerosis, scleroderma, and many other connective tissue diseases. Those patients have to be extra cautious, and physical distancing or social distancing is one of them. And the mask is very, very important, because in our country, we never know where you get the infection from. We do not know still that community spread has come or not. Let us believe it is not yet in the stage, it is not still in the stage of community spread. But places like hospitals can become quickly the hotspots in our country. So the patients should not come to hospital unnecessarily, as Medical Council of India allowed teleconferencing or telemedicine, video conferencing with the patients, and you can give consultation for the routine purposes. The government has taken enough steps now to overcome the drug shortage, and I think the drug supply chain is being restored. I think the government has done an excellent job, better than many other countries. And I think we have to bear with minor difficulties which you overcome in lockdown. In fact, I must tell you that this is just not enough. We need to have minimum 10 weeks of lockdown before we can start graded withdrawal, because the COVID has minimum 2 to 4 weeks of incubation period, and it can survive in a human host for up to 6 weeks. So if you can break the chain by keeping people at home, you might get away with asymptomatic people at home itself. They may not come out to the community. Yes. And I have been campaigning for this for last almost a month. And yesterday the Lancet has published, Lancet editors told that India needs minimum 10 weeks of lockdown. And at the end of 10 weeks, the residual load in the community will be very little. And that is one thing. And number two is, I also campaign for homemade masks. And this is made by my wife. She's a doctor herself. And this is, I've been telling from the beginning, because the size of the COVID virus is very large. That's to our advantage. If you make a simple cloth mask with 2 layers even, not even 3 layers, the virus cannot penetrate. So if everybody wears, 90% we can reduce by wearing masks. The Western society do not accept it, so they are very much, they can't compromise in the comfort zone. But we have to survive. For us, it's a survival question. The patients of rheumatic diseases who will be requiring the various immunomodulators and immunosuppressants may be at a higher risk. We do not know. As of now, there's no data. But certainly I must warn that our patient should be extra careful. They should not change their treatment without consulting the doctor. They should continue that. With the slightest doubt of fever, cough, breathlessness, they must consult. They must get themselves tested if they qualify for it. And at that moment, when the suspicion comes, they can stop certain drugs, but not everything. Like American College says, you can continue hydroxychloroquine, methotrexate even, sulfasalazine, and regular drugs. But immunosuppressions like hydrosteroids and rituximab, maybe we have to be a little cautious. There's one biologics called tocilizumab, which blocks interleukin 6. It may be even beneficial in the advanced stage of COVID. But it doesn't mean that you give it to people who do not require it. Just like that, giving may not help. It's only in advanced stage. So it's a very complex scenario. Our patients need to be extra careful because they are on regular drugs. They should not play with the medications. I have so many phone calls, so many messages, patients asking for changes in treatment. So I told them to stay on and consult their local rheumatologist with the help of video conferencing or telemedicine facilities.
Thank you so much, Dr. Danda. Very useful information, and I must compliment your campaign for homemade masks. And this is the need of the time, and everyone is, insisting. And I'm sure that even the government of India has made it mandatory to wear the mask. So people and who are watching, around, we are seeing 1.5 thousand people are watching this program as of now live. I would request all of them also as well to make sure that they wear mask, and they also try to make mask at home. And should listen from Dr. Danda on this, because making mask at home and keeping it clean and hygienic makes it more easy to maintain rather than buying a mask from market. Uh, we have passed around 33 for 35 minutes on the live, and we are getting a lot of questions from Facebook also, our viewers. So I'll pass on the second question on Dr. Uma. And Dr. Uma, there's a question from a Facebook user, and he's asking that are there any new treatments for ankylosing spondylitis other than biologics, DMARDs, NSAIDs? Are we discovering stem cell treatment or gene editing also in this area? Quite a technical question. I'm sure the viewer is much more informed and educated on the technical side of it than me itself. So, Dr. Uma, you put some light on it.
Look, initially we used to give patients just simple non-steroidal anti-inflammatory drugs. Then there are various types of non-steroidal anti-inflammatory drugs, and then came under that category COX-2 inhibitors. Then patients started taking that. Then we had anti-TNF inhibitors, and there are multiple drugs under that category. And patients are actually getting benefited with it. And now it has been said that those who are on these drugs for years altogether, for more than 5 years, even structural modification has been seen. It's just not halting the disease. In fact, some reversal is also being seen. So, and then came other group of drugs like IL-17 inhibitors. There are lots of anti-cytokine therapies available. Then spondylitis again is not the single disease entity. There are multiple conditions included under that. That could be psoriatic, that could be IBD associated, which is inflammatory bowel disease, which includes Crohn's disease and ulcerative colitis. Then there are categories which happen in juvenile age group. So there are multiple conditions included under that. And then that also actually is to be considered while deciding the therapy. And even, there are other groups of therapies which are tried in patients who are having spondyloarthritis peripheral. That means the spine is not involved, axial skeletal is not involved. In that group, we have the small molecules, we have other phosphodiesterase inhibitors group of drugs. So in this forum, it's better not to name the drugs which are being given in this group of patients. And I would like to, and as he talked, somebody has asked about stem cell therapy and gene editing. Look, these are all experimental therapies. They are not being recommended for the treatment of spondyloarthritis patients. But having said that, I would like to inform the audience and the public that we have pretty efficacious therapies available for managing and treating these patients. And the more important thing is that patients should take drugs very religiously under the supervision of the treating rheumatologist, and they must make physical activity as part of their treatment. And they should also get investigated themselves for various comorbidities which can happen in these chronic inflammatory states like diabetes, hypertension, that also poses problem subsequently.
Thank you so much, Dr. Uma. And I think it addresses the question of the viewer. I think what is, this, how I can sum it up is that uh, look for the medication which your doctor is advising. Don't look for the new innovations. The experiments can go on. And whenever there will be something which is beneficial for you, your doctor is going to, recommend that to you. So don't worry about stem cell, focus on the medication which you have already got. Let me go to Dr. Gangadhar. Sorry, Dharmanand. Sorry, I'm so sorry. Dr. Dharmanand, actually, 2 days back, we were having a session on mental health, and Dr. Gangadhar from Nimans was there. So sorry for mixing up the name. Dr. Dharmanand, we have got an interesting question from a 63-year-old patient, and who is on acute, chemotherapy for acute undifferentiated leukemia. But suddenly from last 2 weeks, he got pain in knee and it's unbearable. Hospital done USG, X-ray of knee, both report are normal. So doctors said it is not osteoarthritis, now only taking painkiller, but pain is not going down. So, what is your broader guidance for this patient? Not to, we are not here to prescribe and consult on a personal level, but at least broader guidance which you can provide.
Yeah, this is a very specific situation, very difficult for us to give a solution without examining the patient in toto. And the patient is a little elderly. He has gone through a treatment for leukemia. Many of the drugs can cause joint pains. And people, when they are undergoing chemotherapy, people can get a disease called gout. I think it is they have to approach their doctors so that they can examine thoroughly and decide on the appropriate treatment. Beyond that, very difficult for us to tell in this forum.
So, doctor, in terms of, let's say this patient seems to have a multiple complication and also is having leukemia. So what are the risks for patients who are on multiple such, they are suffering from some kind of other diseases or comorbidities, and what kind of risk you look at, these set of patients?
Risk during COVID era, that's what you mean?
Yeah, this is especially during the COVID era.
Yeah, as my previous speakers have told already, people who are elderly, who are on chemotherapy drugs, that is immunosuppressive drugs, are at a very high risk, at a higher risk than normal population to get any infection, including COVID. Yeah. So this patient has to probably self-isolate himself or shield himself from potential infections. So he has to be at home and avoid public transport, avoid crowded places. Probably, except for medical emergencies, you should try to get teleconsultations. And also the people who are living with him has to practice very strict self-isolation and social distancing so that they don't go out and get the infection and give it to the senior gentleman.
Thank you so much, doctor. So let me take another question from the Facebook itself, and I'll go to Dr. Shashank for this. Dr. Shashank, the question here is the patient diagnosed as connective tissue disorder with hypothyroidism. She is suffering from moderate joint pain and manifestation of rashes at nose, ear, petals, and scalp. What do you make out of these symptoms, and what is the broader guidance for this patient?
Can you just repeat the last sentence? What does she have?
She has moderate joint pain and manifestation of rashes at nose, ear, and scalp.
Okay. Looking at this patient, again, till the time we see the patient, we can't really get into absolute specifics, but this would be a generalized sort of an answer.
Yeah.
One, she has two conditions which are totally different. One is hypothyroidism, and secondly, the undifferentiated connective tissue disease. The joint pain and the rash can be all related to her connective tissue disease. Hypothyroidism generally would not cause a rash, and very rarely joint pain in the setting of connective tissue disease. How can she go forward? The very fact that she has rash and joint pain, that means her connective tissue disease is not adequately controlled. So she has to get back to her rheumatologist, talk to the rheumatologist, and get the doses adjusted. Adjustment in the doses would mean the disease is better controlled. One. Secondly, rash in cases with connective tissue diseases is generally sensitive to light. So if she has exposure to ultraviolet light, now probably in this lockdown phase, she may not be going out in the sun, but otherwise, sun exposure is something that not only causes rashes, but can also cause a flare-up of her arthritis, of her connective tissue disease itself. So she has to protect herself from the sun, preferably avoid going out in the sun. If she has to go out, a scarf has to be there, full sleeve rather than half sleeves. An umbrella would be a must, and a good photoprotective lotion is there. Secondly, in the house itself, what could be the other sources of ultraviolet light? Too much of screen exposure, not the mobiles, but the TV as well as particularly the PC screens at times. Too much of exposure to sunlight that is reflected in the house. So there may not be a direct sunlight, but something that is reflected. So she can use a good amount of curtains, dark colored curtains, so that there's not much of sun exposure, indirect sun exposure in the house. So one, taking care of the sunlight exposure, and secondly, get back to the rheumatologist. The arthritis definitely doesn't seem very well controlled, and I'm sure she has mild symptoms which could be very well controlled with modification of the medicines.
Thank you so much. I believe this addresses their concern. We're getting a lot of questions, so I actually wanted to go on a disease-based precautions during the COVID era. But I'll take one more question from one of the patient or the viewer from Facebook, and I'll go to Dr. Aman for that. Dr. Aman, there is a question: how frequently inflammatory bowel disease and ankylosing spondylitis overlap, and which shall be treated first? 2-3
Actually,
are asking this question actually, and also there's a question that patients taking Enbrel
can you hear me?
are at greater risk of getting COVID-19. Is this a question mark? That are they at greater risk? I don't know. They are mentioning a certain medicine here. So you may like
yeah, I can make that out. So there are two parts to this question. The first one is IBD and ankylosing spondylitis. So as Dr. Danda and my previous speakers have said, it comes under the umbrella entity what we call as spondyloarthropathy. Spondyloarthropathy, there is IBD associated arthritis. It can have back pain or inflammatory low backache, as it was alluded to, and it can also have peripheral arthritis. So the association is very well established and has been known for very long. So if the one short answer is there can be inflammatory arthritis of the back, which some people say ankylosing spondylitis kind of arthritis, which we call as axial spondyloarthropathy, and also the peripheral form of arthritis, knees and elbows, which can also occur. So both these joint diseases can occur in the presence of inflammatory bowel disease like ulcerative colitis or Crohn's disease. That is number one. Number two is regarding Enbrel. Enbrel is, again, as Dr. Uma had previously alluded to, Enbrel is an anti-TNF agent. So it's one of the modalities which is generally used for back related arthritis, what we call as axial spondyloarthropathy, which is not responsive to the garden with the painkillers, as the lay people call it, and we call them as NSAIDs. It is for and the patients with IBD cannot use an NSAIDs generally, so there probably this can have a role.
Thank you so much, doctor. So let me now go to the condition specific guidance from you people. And I'll start, maybe there's some part of repetition also, but since our Facebook viewers new viewers keep connecting, and maybe old viewers get dropped off also in between, so there may be some kind of repetition as well, which will be useful for them. So let's go to the rheumatoid arthritis as a condition and the precautions and a little bit of prevention. And I'll take this question to Dr. Danda again, and to give a little bit more detailed question on this particular condition, which where you can cover, doctor, the broad definition of this disease and what are the risks involved during COVID era, and what are the preventive measures you suggest?
Good question. Rheumatoid arthritis affects almost 1% of human population. So it's a fairly large disease burden. Rheumatoid arthritis is a multi-system disease. It is not just arthritis. Most patients think it is just a joint disease. It is diagnosed by a set of classification criteria, which is not strictly a diagnostic criteria, which I'm not going into it. Your doctors can go through the classification criteria and they can diagnose fairly easily rheumatoid arthritis. Because it's a multi-system disease, we have to pay attention to extra-articular features, that is, the patient's other organs, which is equally important than the joints. The joints will not kill the patient, but the complications involving heart, lungs, and other major organs can give rise to serious morbidity and even mortality. So therefore, the treatment of rheumatoid arthritis, which is a systemic autoimmune disease. Briefly, an autoimmune disease, if I can say in a very oversimplified way, it's like, say, our soldier sitting within the fence of our own border and by mistake attacks another soldier from our own army, mistaking that as an enemy. So it's like killing your own friend or your own relative, thinking it's an enemy. So our immune system is a soldier, which normally can differentiate normal or the normal healthy tissue from the enemies like the virus or cancer or all that. And this system sometimes does this mistake. It doesn't happen by chance. There are some genetic predispositions and there are some triggers which you do not understand very well. Environmental triggers, which could be an infection, and many other causes are suspected. So in a systemic autoimmune disease like rheumatoid arthritis, our immune system attacks our own body and causes, it's like a rogue immune cell. So if you have a rogue immune system, it's like a rogue boy in your locality. If he's not allowed or suppressed, he will form a gang and then he may spoil the whole locality. So the treatment principle of rheumatoid arthritis is keeping those rogue elements under check, under suppression. There is no cure. But I must tell you one thing, the word cure means differently from patients to doctors. What we mean by cure is that we can stop the treatment and the disease disappears. That is cure. Whereas for patients, if the symptom gets better, many of them think it is cure. With apology to other systems of medicine, many times this creates a confusion. The people claim to cure rheumatoid arthritis. It is not curable. It is controllable to a large extent, as much as the patient starts feeling I am cured. But if you stop the treatment, within few months, things will come back, maybe in a much worse way. So it's a lifelong, systemic or multi-system autoimmune disease affecting many systems in the body.
Dr. I may just interrupt you briefly. Your mobile phone is on, which is creating a little bit of sound disturbance for audience. So if you can switch it off maybe for some time.
Yes.
Thank you so much, sir.
Here's the Facebook, yeah.
Yeah. Please, yeah, please.
Okay.
Sir,
So what I said so far is basically the rheumatoid arthritis is a multi-system disease. It's not just arthritis. It's lifelong nature. It is not curable, but it's treatable to an extent that patient can have near normal lifestyle. And the treatment cannot be stopped, though doses can be monitored and reduced. There's so much of options of treatment in rheumatoid arthritis today. The patient of rheumatoid arthritis today is much different than what it used to be 30 years back. And in fact, nowadays, when for MBBS exams, people ask for a classical rheumatoid hand, sometimes you don't find them. So that's the magic of the wonderful targeted treatment. Not only expensive biologics, but a judicious use of cheaper common drugs like sulfasalazine, methotrexate, and hydroxychloroquine makes a difference. So rheumatoid arthritis is therefore a highly treatable disease, and the patient should not get upset about it. Now, what they should be worried about during this COVID season? Well, I'm not a COVID expert, but you can see there is so much of misinformation all over the place that patients are likely to get confused by this information. The first thing patient must know, as I've told a few minutes back, is please stick to your doctor's advice. If you have symptoms of cough, breathlessness, fever, please consult the hotline, and if they make you, if they like to investigate you, they will do. If there is a suspicion at that stage, you can still continue hydroxychloroquine and sulfasalazine. You can, for benefit of doubt, stop the other drugs, but not at this stage. And I must tell you that any of these drugs of rheumatoid arthritis do not make you extra susceptible to get COVID. But comorbidities, yes. I myself is a high risk person to get COVID. Anybody above the age of 50, more so after 60. With, if there is a hypertension, diabetes, heart disease or lung disease of any form, which is present in many rheumatoid patients, are at high risk. So you have to take extra care. The only vaccine available now is to wear a mask. I can tell you, wearing a good mask is more powerful than physical distancing. The physical distancing is very hard to do, but we have to still maintain. Please listen to the government instructions. Don't run around here and there. Don't look for remedies into all kinds of claims. Nobody can cure COVID. There is no specific drug. All are experimental. And once you get tested positive, you have to get away from the family. You have to be treated. But I can tell you that good news is more than 80% of infected people recover and survive. And overall mortality is around 5%. The Europe and North America, it's about 10%. And our mortality is so far is not too bad. It's about less than 5%. But the people who are immunosuppressed, people who expose themselves knowingly, or who knowingly they have COVID, they have gone to doctors hiding facts that their relatives in the family had COVID. I think it's a humanitarian crime. No one should do that. I feel as a citizen, responsible citizen of this nation, you are not just a patient. You will not get any benefit by killing a doctor. You have to be careful to protect yourself, your family, your friends, and your doctors in hospital. Remember, the doctor you have or the hospital staff you have infected will pass it on to another 100,000 people. So by infecting healthcare workers, you are doing a crime to humanity of infecting others. So please don't take it lightly. Nobody is immune to it. There's no way you can make yourself extra immune by eating some food or something. There are so many claims. Just eat your normal food and just have good sleep. Sleep for 8 hours plus. That's what WHO says. Eat for minimum 8 hours in 24 hours. Eat a healthy, balanced, nutritious food. Stick to your normal diet. Our Indian diet has very good antimicrobial property containing spices. But don't think eating in buckets of spices will kill COVID. You can eat neem leaves, you can eat turmeric, you can eat all the spices you like. But I can tell you, they also help in rheumatoid arthritis. They also help in cancer. But how much? These spices will do this much. The medications, specific treatment rheumatoid will do this much. So it's nothing. It's like a drop in the ocean. So if you leave in that, you stop your regular treatment and start some naturopathic treatment, you are going to be in bigger danger. You please continue what you are taking. Please don't stop anything without consulting your doctors by video conferencing or teleconferencing. But do not mix up, because this, have you heard of a word now called COVID-idiot? There are so much of idiosyncratic thoughts all over that people are getting more misinformation. So I like the word COVID-idiots. So there are many people in the society who are spreading such information, and we are equally ignorant as you are about COVID. So only thing we can do is we can prevent, and the prevention by wearing a good mask all the time moment you go out of your house, and maintain distance, continue treatment, sleep well, eat healthy. There's no other magic. And 80% chance you will, even if you get infected, you will survive. If you have a risk factor like hypertension, diabetes, heart disease, lung disease, you have to take extra care. If you have taken rituximab or high dose steroids, consult your doctor and be extra careful. Maintain distance even within the family. Thank you.
So much, doctor. I'm sure you, apart from specific guidance for how to, prevent or take care of rheumatoid arthritis, you have also given people a general guideline so that how to take care of their health overall, and also contribute to the overall fight against corona also by not indulging in, going to a healthcare worker without if they have any kind of symptoms or suspected of having COVID-19 because of any of their exposure. Thank you so much. Let me go to the other disease area so that we can cover. We have already passed almost an hour in our discussion, so need to cover a lot of diseases, apart from this. So let me go to Dr. Uma Kumar again and then ask for psoriatic arthritis, doctor. What is it? And, the patients who are already having this, what is the guideline for them, and, how they should manage it well, and also for those who may have the risk of developing it, how they can prevent it.
Like psoriatic arthritis, one needs to understand there is skin problem and there is issues in the joints. So sometimes what can happen that individual may not have skin problem and can still have joint problem, right? So, and that can actually proceed by years, more than 10 years or 15 years. And that point of time, it is very difficult to make out that this particular patient has psoriatic arthritis or not. Patients, if somebody in the audience is having psoriatic arthritis, would be aware when goes to the doctor asks, do you have anyone in your family having psoriatic arthritis? Because if family first degree relative has history of psoriasis, and then the individual which is coming to the doctor has arthritis and no other manifestations or symptoms, then likely the diagnosis is psoriatic arthritis, right? And then again, in this particular arthritis, lots of comorbidities can happen more commonly because of the inflammatory states. These patients can have obesity, can have intolerant glucose intolerance or diabetes, can have coronary artery disease. So prevalence of all these comorbidities is found to be pretty high in this group of psoriatic arthritis. And these patients can also have nail changes, right? May not have problem in the skin per se, or having, seborrhea kind, excessive dandruff in the skull. And again, for this kind of arthritis, these patients are to be treated adequately. And again, that when doctor decides the treatment, what outcome is expected is that there should be symptomatic relief. Patients should not develop any comorbidity related to chronic inflammation, and there should be no recurrence of the disease, and damage has to be controlled. And there are various medicines available for this particular problem also. I cannot see the audio. Video. And there are various classes of drugs, starting from disease modifying anti-rheumatic drugs to biologic agents, anti-TNF agents, right? And then interleukin inhibitors. And then there are small molecules, various kinases available. Then again, other group of drug, which as I had mentioned previously, phosphodiesterase inhibitors, apremilast. So there are lots of, and then there are various types of psoriatic arthritis. It can involve mono, it can involve oligo, more than one joint, and then patients can have axial spine joint involvement, where it's called psoriatic spondyloarthritis. So again, here the treatment, as I said, we have to focus on control of disease activity in these patients. There's no cure for the problem. This is very much treatable conditions. But other question which comes to the patient's mind is, why should I go to the doctor? My disease is already controlled. Here I would like to emphasize that doctor needs to assess the disease activity of the patient objectively by examining the joint, by examining the skin, by looking for occurrence of any new comorbidity. Second, these patients are on drugs which do have some side effects, and certain investigations are advised to the patients, and they need to do regular investigations as advised their doctors. So they must follow up with their rheumatologist or any other treating doctor regularly, and all drugs must be taken under the supervision of the treating doctor.
Thank you so much, doctor. I think it gives quite a comprehensive understanding about the disease and how to go about it for the patients. Let me go to Dr. Dharmanand now. And my question, doctor, to you is about another condition called lupus. What is this condition, and how many people are at the risk of it? What is to be practiced during COVID-19 era, and what
Lupus is also called systemic lupus erythematosus. It is one of the common autoimmune diseases which can affect women. It affects women of childbearing age group, that is from 15 years to 40 years. And almost 1 in 2,000 people in the world have this disease. This is not an uncommon disease. The difficulty with this disease is it's a multi-system disease. This disease can be very simple disease affecting only the skin, or it can be life-threatening, affecting the brain and also the kidneys, heart, lungs, etc. Some of these patients also have a tendency to have recurrent abortions. They can't retain their conception and they abort frequently. Some of them do have blood clots. So this is a complex multi-system disease. And the standard treatment for that is hydroxychloroquine, which is touted now as a drug for COVID-19 also. And also they are treated with steroid and immunosuppressives depending upon the severity of the clinical manifestations. Some people with skin disease only, they will have hydroxychloroquine only, nothing more. Those who have joint pains and SLE, they may have some immunosuppressions. Most of the patients will have a small dose of steroids. And the problem after the COVID-19 is the hydroxychloroquine has gone out of market, and for this particular disease, it is a life-saving disease, drug, and sudden stoppage can result in a serious flare of a disease or increase in disease activity, which can be sometimes even life-threatening. So we appeal to the government so that this drug is on constant supply. So that is very important for these patients. Because these patients are on hydroxychloroquine, they are not shown to be immune to COVID. So they are also susceptible like anybody else to develop COVID infections. And the good news is there is no hint so far from the literature, studies from other countries, that people with lupus will have a higher disease burden or they die much more than others. So the risk is same. Probably these people are younger. They generally do well. And because they are going to be on immunosuppressives, they have to practice self-isolation very, very strictly during the next 2 to 3 months. This is very important. Self-isolation means they have to avoid going in public transport, avoid large gatherings, and work from home, stay at home most of the time, and don't go out for small things. Let somebody else from the home go. And if they meet anybody, if anybody in the family have symptoms suggestive of COVID, they have to almost shield themselves against these patients. And everybody at home should practice government recommended self-isolation and social distancing.
Thank you so much, doctor. Quite an elaborate answer. So we have another disease area which we have been discussing for some time also here on this discussion, but let me go on a more detail to Dr. Shashank for this. And Dr. Shashank, ankylosing spondylitis. And during the discussion, this word came multiple times. Please put some light on this particular condition, its symptoms, people who are already having it, how they can take care during the COVID-19, and the prevention for those who may be at the risk of developing this. Dr. Sasank.
Spondylitis. Yeah, first of all, let's understand for everybody, for those who have and for the caretakers, the family members of patients who are having ankylosing spondylitis, what exactly is ankylosing spondylitis? Something that we have been discussing we have discussed it so many times during the last 1 hour. It is an autoimmune illness. What does one mean by autoimmune? Body's own immunity starts thinking that the joints are foreign, starts attacking the joints. This attack on the joint leads to swelling in the joint, and that is what causes the pain. Then, which joints are involved? Which joints are attacked by the immunity in ankylosing spondylitis? One, sacroiliac joint. Sacroiliac joint is the joint that is situated just beneath the buttocks. So one would have pain in the buttocks. Second, it also involves the vertebral joints. पीठ की रीढ़ की हड्डी जिसे बोला जाता है, उसके जो जोड़ है, it affects those joints. Thirdly, it affects the joints that attach the ribs to the vertebrae. तो फसली जहां पे रीढ़ की हड्डी को चिपकती है, those joints. So what would one have? One would have pain in the back. It could be the entire back, right from the neck to the chest area to the lower back, and then alternating pain in the buttocks. When is this pain maximum? Generally, it is maximum at night. Once a patient falls asleep, the pain starts increasing. There are so many patients who would wake up at 4 o'clock, 5 o'clock in the morning purely because of pain. Once a person is asleep, turning in bed is very difficult because these joints get swollen because of inactivity during night. When one gets up in the morning, bending, picking up things is very difficult. This is something called as morning stiffness. As the day passes, as the movements start, the pain and the stiffness goes on reducing. This is what generally ankylosing spondylitis would present with. A few patients would also have pain and swelling in the other joint. This is called as peripheral arthritis. The other joints would include ankle, knee, feet joints, hand joints. An occasional patient would have inflammation in the eye as well. So the same immunity that thinks that the joints are foreign at times attacks the eye as well. This is called as uveitis, which can occur in an occasional patient with ankylosing spondylitis. So what can we do about it? In fact, the first question that we just saw, I'm impressed. I was very happy. I was really impressed with the question that the person who was asking the question knew about NSAIDs, knew about DMARDs, knew about biologics. That is exactly what we want. We want the patient to be educated, should know about the medicines. An educated patient is an intelligent patient and can take better care of himself. So this is exactly what we would like. He did ask a question as to whether we have newer modalities, but believe me, with whatever we already have, we are quite better off. We are quite able to manage most of our ankylosing spondylitis patients. You can do well with whatever medicines that are available as of now. You don't have to keep on looking for further things. Can we do? Just saw NSAIDs in analgesics is they are non-steroidal anti-inflammatory medications. So they actually reduce the inflammation in the sacroiliac joint and the vertebral. This is, ankylosing spondylitis is one of the few conditions in which long-term NSAID therapy has been scientifically shown to be useful. At the same time, obviously, one will have to be careful about the side effects. The main side effects of the NSAIDs being problems related to kidney and hypertension, blood pressure. So if you are under a rheumatologist, if you are taking NSAIDs in the long run under supervision of a rheumatologist, this would be definitely taken care of. Apart from NSAIDs, we also have sulfasalazine, which is one of the molecules,
and the institutions, that how they should respond to the need of these patients and how they should be taking care of themselves. So I'll go to Dr. Aman Sarma first for his brief description on vasculitis. Doctor, this is the disease area which I want you to, kind of explain a little bit to our viewers.
Oh, I think I'm very happy that you asked me this question, and my panelists would understand why you asking me this, why I am happy. So my special interest is in this area. My area of research has been vasculitis. So as the name suggests, vessel is a blood vessel. I mean, the term, and itis is inflammation. So vasculitis is inflammation of the blood vessels. So as we have been saying since the very beginning, that the rheumatic diseases are multi-system diseases. So as everybody knows, that every cell in the body is dependent upon the blood supply which reaches that cell or a tissue, which starts from the heart and starts with the bigger blood vessels, then goes to the relatively smaller blood vessels, and eventually the smallest, which enters into the different tissues, whether it is heart, the brains, the lungs, and everywhere else. So there why this background? Because we need to understand vasculitis is a one single term for very different group of diseases. So there are group of diseases which come under large vessel vasculitis. We did talk about giant cell. Dr. Danda did talk about giant cell arthritis, and there is another group of Takayasu arthritis, which he is very much interested in. Then there is a medium vessel vasculitis, wherein it is called polyarthritis nodosa. And then there is a new entity which has some genetic link called deficiency of ADA2, which was described only as late as 2014. And in India, we have the largest cohort. And then there is a small vessel vasculitis. To cut a long story short, and my interest is in small vessel vasculitis, when the diseases present in the multi-system involvement, say for example, in the large vessel vasculitis, you can have strokes, you can have hypertension, you can have cardiac involvement because of Takayasu, and various other organ involvement. You can have blindness, you can have headache, and you can have ballooning up of the larger vessels of the aorta in giant cell arthritis. In medium vessel vasculitis, you can have strokes, you can have nerve damage causing limping of the upper limbs and the lower limbs becoming limp. You can have blood coming out of the intestine. You can have bloody stools. One can have very abdominal pain. There can be infarction of the gut. Then there can be heart involvement. There can be other manifestations on the skin, very big skin rashes, skin ulcers. So if you have skin ulcers with other involvements, you think about medium vessel vasculitis. If you have rapid oncoming lung and renal involvement, for example, somebody has had a fever, cough, breathlessness with blood coming out in sputum, what we recognize as lung hemorrhage, along with advanced renal failure. So the creatinine, which is a renal function, was normal, and very fast it becomes abnormal. What we understand as lung and kidney involvement simultaneously, what you call as renopulmonary syndrome. Then Dr. Uma talked about oral ulcers and genital ulcer. There is a vasculitis which is variable vessel. Variable vessel means it can involve the larger vessels, it can involve the medium vessels, and it can involve the small vessels. But there is a very severe eye involvement also, leading to blindness in up to 30% of the patients. I can tell you. And one other thing which the COVID and vasculitis connects, there has been an expert who's been standing right behind the US president, and his name is Dr. Anthony Fauci. He's been talking about the early things about hydroxychloroquine and everything else. He was a guy who's been associated with bringing a landmark change in these universally fatal diseases. The watershed area was 1971. Before 1971, small vessel vasculitis was 100%, almost 100% fatal. But after that gentleman, who's now associated in the war against COVID in the US with the US president, they introduced a drug called cyclophosphamide, and that universally fatal disease became chronically manageable disease, and wherein now it's become like diabetes and hypertension. Not that everything is all right now, but these diseases now are much better managed. And we have a very robust, active Indian Rheumatoid IRA-VAS group, which has been at the forefront of vasculitis research. And I think the most key message is, whenever you see a multi-system involvement starting from the heart, brain, lungs, kidneys, skin, nerves, think about vasculitis. And unless you pick it up early, it may produce damage to the organs, and it might be very rapidly fatal also.
Thank you so much, Doctor. 10 minutes left for our session. One question has come up from our Facebook, and it again seems to be and sounding very informed question, and apparently might have come from some doctor or practitioner himself. I read out the question, and then please let me know who one of you would like to answer that. The question is: the two biologics got failed, etanercept and adalimumab. Why it is not in practice to do cytokine and biomarker profiling before initiation? Any biologics therapy targeted drug can be given. So this is the question. Who would be the right person? I think Dr. Uma is smiling on it. So let me go to Dr. Uma. Dr. Uma, if you would like to give some understanding on this question.
Look, he's talked about ankylosing spondylitis, if I'm not wrong. So to understand it better, these are all inflammatory arthritis. And if we talk about cytokines like IL-6 inhibitor, which is tocilizumab, there is a TNF-alpha inhibitor, many biologics in that like infliximab, etanercept, there is IL-17 inhibitor, secukinumab. So they are all inflammatory markers, IL-17, TNF-alpha, IL-6. So, and all patients who have inflammatory disease will have elevation of these cytokines. And these diseases are not governed by simple pathway. They are all polygenic diseases, right? So in one patient, one drug can work, in another can work, and just looking at a marker, sometimes these inflammatory markers just help us to decide the treatment, that we have to be more aggressive in a particular patient, right? But just measuring these cytokines cannot really help us in deciding in patients that, okay, this angst patient would be benefited with this particular drug, or that rheumatoid patient would be benefited with that. But yes, I agree. Sometimes, if patient is seropositive in cases of rheumatoid arthritis, where their anti-CCP, which is a kind of autoantibody, is positive, or rheumatoid factor is positive, then we think seropositive, then we can think of choosing, B-cell therapy, which is rituximab. So those are the things which can help. But just by doing a particular cytokine in these common arthritis which we talked about can help us in deciding and choosing the treatment is absolutely incorrect. It cannot help us.
Hopefully,
maybe my colleagues would like to add to it something.
Dr. Danda, I want to add on.
I think,
Dr. Dr. Dharmanand. Let me take Dr. Dharmanand first, Dr. Danda. Then I'll come to you for the remark. Yes,
See, every doctor's dream is personalized medicine. If we can decide for the particular patient which drug is going to work, is the ideal goal or ideal situation. Still, we are not at it at this moment. We are not able to predict reliably which patient is going to respond to which type of drug or which biologicals, even after doing the cytokine levels. There are multiple studies are going on, very promising biomarkers are in the pipeline. But at this moment, it is hit and run, trial and error. So we have to try one this. If this is not better, and we can try the other one. Of course, as a doctor, we choose the drug in the most intelligent way. We choose the right kind of person. We think that the most likely fit, we will give the drug. But still, sometimes our judgment might fail, and we may have to resort to the other drugs. But in the next 10, 15 years, it's going to be reality. There is a lot of work going on in personalized medicine. Biomarkers are in the pipeline. Maybe another 10 years, we may be able to tailor-made a drug for the patient.
Thank you so much, Doctor. Dr. Danda, let me come to you for the final remark later, because we are already almost 7 minutes left to our 5 minutes left to our discussion. So now I'd like to take the overarching remarks, the closing remarks from all our experts, and we'll start from Dr. Shashank on this. And I would like, Shashank, you to cover that. Broadly, we have discussed all disease areas, but what is your broader message for patients in the COVID-19 situation, where the fear, anxieties are very high. Every disease, any patient who is having any kind of disease or existing diseases have a lot of apprehensions going on. There is also some message you may like to give to your fraternity of doctors and healthcare practitioners related to their availability for the patients through technology and through digital mediums. And also, what is your expectation from the government in terms of their contribution or their support for taking care of patients related to these disease areas? So, Dr. Sasank, over to you.
Yeah, a few things from my side, a few observations, in fact. What is happening to most of us? See, I am doing video consultation, so I'm still in touch with patients through video consultation as well as through social media. I'm quite active on social media. The observations that I'm regularly seeing in patients is one, the patient workload has increased. In particular, since the maids are, the workload has increased. That tends to trigger the arthritis process. The pain goes for a toss, pain and the arthritis. Second, many of them are not taking good care of themselves. So one of the important messages is, see, obviously the work is more, everything is there, but don't forget about your own health. Don't forget about the arthritis. You have to take good care of your arthritis. What do I mean by taking care? One, not forget medicines. Many of the getting to take their medicines on time purely because of the increased workload. Second, you may be going out on a regular basis for exercise outdoor. That is not possible now. So somehow most of the patients or many of the patients have given up on exercises during this phase. This is the phase wherein you should again concentrate on your exercises. Do exercises on a regular basis. That reduces the stiffness, reduces the pain, and keeps you flexible, particularly so for ankylosing as well. Thirdly, stress, anxiety, obviously everybody is affected by this, but I'm sure you have more important things to look into: your arthritis, your family, your work. Concentrate on that. If you find any particular trigger that is increasing your anxiety, something like watching the television, going through WhatsApp chats about COVID things, try and avoid that as much as possible. I'm sure you have your arthritis, your own health, your family to look after. Why get into something that is triggering the anxiety? So these are the important things. Lastly, availability of medicines. There could be some issue, but most importantly, get an extra stock of medicines wherever it is available. Keep that extra stock with you so that maybe 15 days more, and don't wait till the last day when the medicines are over. Buy them well in advance, 7 days in advance. That will take care of the entire thing. As far as government is concerned, already I think government is doing quite well proactively in this COVID situation. Only thing, from all the patients, all rheumatology patients, there is some amount of shortage of hydroxychloroquine. If government can do something about that, that will be really great for our patients.
That's an important point, doctor. We are exporting this medicine, and you are highlighting shortage of it in India. So I'm sure there is a possibility of government to reverse this situation for sure. Let me go to Dr. Aman Sharma. Brief remark, Dr. Sharma, about the same three areas: your broader, guideline for the patients, and request and expectation from your healthcare fraternity towards these patients, and what do you expect from the government?
I mean, three things. First thing is we have to change culturally. We have to go back to our old culture, and I think we have to go back to, from now forever, we have to go to namaste. I mean, we have to shun the culture for shaking hands. I think this is something which can avoid multiple infections being exchanged from one person to the other. The second thing is I think this has been an awakening. We've been talking about Swachh Bharat. The Prime Minister Shri Modi has been Narendra Modi ji has been saying so emphatically, and I think this has been driven home by this that we need to keep care of the sanitary conditions, and we should be washing our hands thoroughly and more frequently. The third thing is what Shashank said. India has been a place for meditation, and I can tell you, There are sessions on mindfulness, even in the American College of Rheumatology sessions, which is something which has been borrowed from meditation. It can surely allay anxiety. I have been practicing meditation since the days of my medical school, and I can tell you it does really help. The doctors many a times work under stress, and if we always complain about not having time. This is a godsend opportunity to spend time with your parents, with your children, with your family, and you have enough time for yourself. One should not really complain. It's been reliving the previous life. I think you should try to meditate. There are enough YouTube things available. The next thing that I wish to say is, I think I must compliment, a doom was being spelt for our country since even before the COVID landed in India. People were saying n number of people will die, so many millions of people are going to die. I can tell you the response, the central government, the response has been phenomenal. And if you compare the figures, which if you start with day zero in India and with day zero in other countries like Italy or New York, India is doing much, much, much better. We see so many discordant voices, I think, but we should only, if there are certain people who are critics and critiques of everything, you can leave the criticism for later part. When you are fighting a war, everybody should try to generate positive energy. This is no less than a war. When you are thinking of losing millions of people, this is no less than a war. Only a positive, and you should come out with solutions rather than problems. If you see a problem, you try to identify. After all, everybody has to pitch in. That is number one. And I can tell you, and my senior colleagues can vouch for it, that India has such a huge capability of producing hydroxychloroquine that we can supply the whole world. If there are problems, there are probably problems in supply chain, which are because of these issues, not because of the problems with production. Already the houses have increased production 10 times. So this drug becoming scarce I don't think it is possible. The only thing is, if there are we have got such a vast country. If there are some minor issues, sometimes you may not get even what you wish to have. So there are minor issues, but there are people who are already trying to address that. And I'm pretty certain. Having said that, whether, the demand, which is non-rheumatological demand of hydroxychloroquine, will stay or will fade away, probably the promise of hydroxychloroquine is not as much as it was supposed to be. So it will come back to the kitty of the rheumatology patients. But I think we should be positive. Positivity at house, positivity at work, and positivity in the country. That's the message that I want to convey.
Thank you so much, doctor. And I'm sure a lot of efforts are being done, and this should be, saving our country, our people in a much more better manner than what we saw in other countries. Dr. BG Dharmanand,
quickly
from your
yes.
side.
So I request my patients, all the patients with rheumatological disease, not to stop medications, stay home, stay self-isolated, practice social distancing, connect with your relatives, friends through social media, and keep up with your exercises. Stay healthy, eat healthily. Thank you.
Thank you so much, doctor. And thank you for being so brief. And it's one of the most powerful messages for sure. Dr. Uma, we have already passed our 1.5 hour time. So, but a brief remark from your side, please.
Yeah, I would like to tell everyone, including my patients, that now it's the time to get back to our roots. We have got very rich heritage, and we must actually try to follow that now, since the opportunity has come. And if we focus on what is required to control this mahamari, this pandemic, is physical distancing, hand hygiene, and cough etiquettes. Everything is given in our Vedas. So this is the time where we should rethink and get to our legacy.
Thank you so much, doctor. Dr. Danda, final remark from your side.
I must say that this COVID has shown that we are nothing but puppets in the hand of nature. Only last year, there have been publications in Nature and Science showing that 50 is the new 30. And today, COVID has shown 50 is the new 70 and 60 is the new 80. So patients and the doctors, we are all in the same boat now. This has come to check us. We had crossed all our limits. We have stretched ourselves. We have stretched nature. So what you can see, that you can see the brighter side. You can breathe fresh air. You can see the birds singing. You can look at the clear sky. You can look at the stars and the moons in the sky. And you have to make it a lifestyle change now for at least a year or two, to wear mask, to maintain physical distancing, frequent hand washing. All these things are going to stay with us even after this pandemic slows down, maybe by July or August. And please, I should say that if we have to survive, if we have to sustain, we have to maintain this lockdown at least for 10 weeks at a stretch, to cover the incubation period and viral persistence, and the withdrawal has to be gradual lifting, maintaining all the hygienic steps that Dr. Uma has said, all other friends have said. Rheumatic disease patients are not any extra susceptible, except those who have got high dose immunosuppression, those who have got lung disease, etc. However, you can take the best possible precautions with the slightest hint, as everybody has mentioned. Please keep a safe distance from rest of the family members if anyone is having cough or fever. Thank you very much. Stay safe and stay healthy. Thank you all for inviting me. Thank you all the panelists, and thank you for the moderator, Mr. Kamal Narayan, for inviting us. I'm very happy to share this platform.
It was absolutely our pleasure, sir, and all the experts today who joined us. So to my viewers on Facebook, here was our special show on rheumatology patients and how they should take care of themselves, and their caretakers should take care of them during these COVID-19 lockdowns. Uh, as our experts mentioned and emphasized again and again, this is a God sent opportunity for all of you. While you are confined at your home, your health remains at your hand, and you can take care of yourself best by moderating your foods, your diets, your exercises, and ensuring that while this earth is healing itself, you heal and facilitate your healing by your own supportive actions. Your doctors are not far from you. They are a call away, they are a video consultation away, and they all are ensuring that you people are safe, you are getting critical guidance at the time when you need it most. So with these words, I would like to close this today's session. I'll thank all our doctors again, Dr. Debashish Dhanda, Dr. VG Dharmanan, Dr. Aman Sharma, Dr. Uma Kumar, and Dr. Shashank. Thank you so much for your time, and we had a wonderful session. More than or nearly 2,000 viewers watched it, and there were so many questions. So I can make out that people loved what you said, and that might have definitely helped a lot of people in managing their diseases, managing their anxiety which they may be facing because of their existing diseases and then the present situation. Thank you so much, all of you. Thank you. Bye bye.